Bulla is above the vesicle. The size is very much large. It is crossing more than 1 centimeter, and it contains almost all time it is contains clear fluid. So these are the 8 pictures you can see. And next slide, I'm going to show the 8 more pictures, and whole of the neonatology skin disorders, they rotate around these 16 slides only. Okay, so in future, so this is the next 8 slides I'm putting in front of you, 8 different skin pictures. So as we have seen previously the bulla, now we are going to see about what is crust and what is scale. Crust is nothing but it is some weight lesion arising from superficial part of the skin, and actually it is discolorated yellow or white in color. Scale is also because of the denudation of the superficial part of the skin, but it is not wet, it is very dry. You can call it as a dandruff like that. So it is a scale is very dry and white, and because of denudation of the superficial part of the skin. Now coming to erosion is denudation of the skin, but the deeper part of the skin is visible because of that. So erosion is like that, it is visible. And ulcer is denudation of the skin with some gapping in between, and there the healing has not started yet, so it is a ulcer. And if denudation of the skin is there in the intertiginous area, so in this picture, if you are able to see the pinna, when it is rotated, when it is folded, you can see here there is a fissure. Then atrophy is nothing but some part of the skin, deeper part of the skin or superficial part of the skin is not formed, so you will find some kind of dent there, so it is a atrophy. And scar, any kind of skin lesion, when it is healed by fibrous tissue, then it forms scar. And then last lesion is lichenification. Lichenification is nothing but the skin is denuded, then it is adhered to the below part, and there are visible markings over the skin, so it is lichenification. So these are the 16 simple pictures or simple lesions. You have to explain all the skin disorders. Now in future we are going to discuss the common skin disorders, which will be described under these 16 terminologies only. And we are going to discuss in very simple fashion. We are not going to discuss any pathophysiology or anything in that. We are going to discuss a spot diagnosis, then clinical features, and how we are going to treat that. Now we are going to see the transient papular and pustular lesions under the following heads of milia, miliaria, sebaceous hyperplasia, erythema toxicum, and neonatal cephalic pustulosis. So we are going to discuss this by seeing this photograph. Now we are going to see, this is a lesion where you can see that white papules are present, and they are more common. See here on the chin, you can see these white papules, and they are more common on the nose tip also. And usually the milia are retention of the keratin and sebaceous material, and usually they dissolve on their own. You just have to counsel the parents when you see such lesions, just wait for few weeks. Most of the time they disappear. So this is milia where only reassurance of the parent is needed. Then second thing we are going to see is sebaceous hyperplasia. So sebaceous hyperplasia, how it is different from milia? So it is also 1 to 2 mm yellow papule which is seen over the tip of the nose and chin, but they are milia are more faint. The sebaceous hyperplasia is more white or more yellow. So you can see more dense lesions over the tip of the nose or chin tip. Then you can say it is sebaceous hyperplasia. And sebaceous hyperplasia also resolves on its own, but sometimes needs very low potency steroids. See, low potency steroids are locally available as hydrocortisone. You can have a little bit higher potency steroids as Desivon and like that. So, but try to use first as a low potency steroids in neonates, and then when they don't respond, then you can go to high potency steroids. Okay, we will move ahead. Now, till now we have seen about milia and sebaceous hyperplasia. They are more or less same, but sebaceous hyperplasia is more denser and more whiter than as compared to milia. Now we'll move on to miliaria. this is the summer month. You can see that a lot of babies will have miliaria, and miliaria is because of obstruction of the sweat duct. And previous two lesions like milia and sebaceous hyperplasia is because of obstruction of the sebaceous glands. So this is because of obstruction of the sweat duct. So what you will find, you will find some vesicles with clear fluid in below that. So if you are able to see miliaria, then miliaria needs actually management of temperature in the surrounding. Then try to consider of low potency steroids. As I told, hydrocortisone containing local creams you can consider for if extensive miliaria are there. So most of the time, if miliaria crystallinea or miliaria rubra is there, they will resolve. But if miliaria profunda is there, then you may have to consider for use of systemic steroids also. I think till now it is very easy for you to understand skin lesions, what we have seen. Now, very common disorder, very benign disorder, which usually doesn't need treatment. Just visual impression of that is going to show you that it is erythema toxicum neonatorum. Usually it appears after 24 hours of life. And usually what you can see a whitish papule surrounded by erythema, and usually seen on the trunk. And the differentiating point here is the palms, soles and genitalia are usually spared. So if you do examination of that, it is usually it contains eosinophils. So it's a hypersensitivity reaction, and it usually resolves on its own. You need not have to consider for any oral as well as local application of anything. Usually it resolves on its own. Most of the time neonatology teach that erythema toxicum needs only observational care, doesn't need anything. Now we'll move on to infantile acne. So infantile acne usually happens if mother get exposed to some androgens during antenatal period. Usually they are seen over the cheeks, and usually they are open comedones or closed comedones. And if these neonatal acne are present, then at that time you should consider for using isotretinoin local creams, or you have to consider for local steroids or some skin lotions which contain antifungals, because most of the time they are infected with Malassezia furfur type of fungal infection. So it's a visual diagnosis only of infantile acne or neonatal acne. Okay. Now after this papular disorders and pustular disorders, we will move on to another disorders, that is focal papules, vesicles and blisters. Here we are going to see about sucking blisters and oral inclusion cyst. So I have tried to put forward such photographs because in skin disorders, see, visual impressions carry a lot of importance rather than the description of that. So we'll try to more focus on the visual impression. So see, this is the hand where we can see that some kind of elevation is there, which is a blister, and this blister contains clear fluid. So it is because of the baby is doing sucking movements in utero, and that has caused sucking blister. And usually if it get discriminated only, then only it needs treatment, otherwise it will resolve on its own. If it is discriminated, then it may need antibiotic local application, and some of the emollients are needed. Okay, so most of the time local antibiotics or skin antibiotic creams usually contains usually we use our mupirocin, because staphylococci are the more common organisms which usually infect skin. And another newer agent which has come as ozenoxacin, we started using that, and it is giving good result for if skin blisters are denuded only. See, oral sucking blisters also are present. Here you can see the oral skin sucking blisters. Usually they need observational care. We'll move on to oral inclusion cyst. So most of the people have seen such kind of oral inclusion cyst. This is called as Epstein pearl. So you can see that in the median raphe of the hard palate, you can see white dots. They are nothing but Epstein pearls. Just counsel the parents. It is nothing. Wait and watch. It will go off. Then such kind of gingival hyperplasia you can see with few of the nodules protruding out. These are the bone nodules, and usually these are the inclusion cyst, usually needs observational care only. Now we are moving to third part of skin disorder, that is skin color changes. So skin color changes we are going to see under the heading of transient vascular changes and some pigmentary changes like Mongolian spot or transient epidermal hyperpigmentation. We'll move ahead. So we'll see these slides. So here you can see that two slides are there. On top right side, you can see that palms and soles of this baby are cyanos. They are bluish in color. Acrocyanosis it is called as, and acrocyanosis is secondary to cold stress. So if such things are there, then you can consider for keeping the baby's temperature in a normal zone and try to warm the child. So baby will recover with that. But another slide which you can see here. So see, this is the back of the child, and half of the back of the child. See, lower part is hyperpigmented, or you can see more pinker as compared to the upper half of the back of this child. Why it happens? Because of autonomic instability. Autonomic instability, what does it cause? It causes pooling of the blood in the with the gravitational force on the lower part of the dependent part of the body, and that is called as Harlequin color change. And Harlequin color change usually is secondary to autonomic instability. Usually it doesn't need treatment, or usually doesn't resolve also with the treatment. Just wait and watch. You have to advise to the parents. Now another skin change which we are going to discuss about is cutis marmorata, and another is cutis marmorata telangiectasia. So I will try to describe them on the same point and how we are going to differentiate them. If you look them, see, this is the leg thigh of the child. It is showing reticular lacy pattern, and here also lacy reticular with some blotching areas are there. Both of them look similar like that, but cutis marmorata usually is secondary to shock, low blood pressure, or baby is hypothermic. Most of the time such cutis marmorata are there, and when we take care of temperature of the child, when we take care of the blood pressure of the child, see, systemic vascular resistance, when it is increased, at that point such kind of cutis marmorata present. And when we consider, yes, we are decreasing age, means systemic vascular resistance decreasing agents like dobutamine, or you consider for keeping the baby's temperature in a normal zone, at that time this cutis marmorata disappears. But cutis marmorata telangiectasia never disappears like that. Even if your baby is euthermic, even if your baby's blood pressure is normal, even if baby's capillary filling time is normal, this is not going to disappear. So what you are going to do for that, you have to think parallelly and try to find out any associated genetic problem in that child. So most of the time, this cutis marmorata telangiectasia are associated with trisomy 13, trisomy 18, trisomy 21, Cornelia-de-Lange syndrome, and homocystinuria. So try to find out other features of that. We are not going to discuss in detail about that because of the time constraint. Now, another common lesion is Mongolian spot. See, this Mongolian spot is nothing but bluish gray patch, usually seen over the lumbosacral region, but no area is paired of that. You can see at any part. If you use Wood's lamp, you will see Tyndall effect with grayish blue hue of the skin, and usually it disappears on its own. It doesn't have any permanent effect, and sometimes baby have diffuse Mongolian spots. You have to counsel the parents that it doesn't need any treatment, and if it is causing some for cosmetic reason, if it is persisting after 6 months of life, then you may treat it with different kinds of lasers, which we are not going to discuss. Now we'll move on to another lesion, that is some hyperpigmentary lesion. So this is female genitalia of a neonate, where you can see that labia majora is hyperpigmented. The knuckles of the baby, they are pads of the baby, finger pads are hyperpigmented. Male scrotum is hyperpigmented. So this kind of hyperpigmentation, when you are seeing with baby having blood pressure instability, potassium imbalance, and usually presenting at 2 to 3 weeks of life of the child, usually it is CAH, that is congenital adrenal hyperplasia. Try to check sugar of the child, try to check blood pressure, send serum electrolytes, and send 17 OHP, and try to treat as a neonatal emergency, because such babies are going to succumb if we are not treating with steroids. Now we'll move ahead with capillary malformation, another skin color change. This uppermost part is nothing but a capillary malformation, where you can call it as salmon patch, or you can call it as a stork bite. Basically, means both these things. Basically, this stork usually it's a kind of bird. When people used to carry food on their head, they used to steal that. At that time, if whatever injury has developed, that is can called stork bite. The lower one is salmon patch, and this one is on the thigh is hemangioma. Just a few important points about that. It's a visual diagnosis. Just whenever you are finding any capillary malformation of the skin, try to wait for 1 year of life, because the spontaneous disappearance is very well explained. When they are present on head, neck, face region, try to do ultrasound with Doppler of head to rule out Sturge-Weber syndrome. That is, any capillary malformation in the brain is there is a no, and then according to that you have to treat. After 1 year, or for cosmetic reason, if you want to treat it early, local steroids like timolol or oral beta blocker like propranolol gives very good result. Laser treatment usually is not needed. We can consider if it doesn't respond to pharmacological therapy. Now we'll see about discriminative lesions. So these are the two slides which I have shown you. This is the picture where disclamation is there, skin peeling is there. So see, disclamation usually is seen in babies who are IUGR, who are post-mature, but more for pathological region. As a neonatologist or a pediatrician, when you are seeing a baby with a slide which is shown down here, where you can see that baby's mouth is wide open, baby is having some flexural contractures, baby's eyes will be wide open because of the skin is very tight. And if it is like that, then you should suspect that it is a collodion baby or ichthyosis. So see, collodion baby usually resolve with their skin regions by application of emollients. Then you can consider for application of paraffin and take care of any skin infection. So with maintenance of hydration of the child. Usually they have a complication of sepsis with hypernatremia. You should treat it properly. But if it is ichthyosis, usually such babies doesn't respond well, and they may expire because of skin infection or hypernatremia or electrolyte imbalance. Now we'll go ahead with diaper dermatitis. See, diaper dermatitis is a most common skin complaint. Most of the mothers are using diapers. So there are guidelines also. If time permits, we are going to discuss about the guidelines about how to use diapers, when to use and when not to use. So just to see this picture, you can see erythematous papular pustules in the diaper area. It is a diaper dermatitis, but most of the time it is confused with few of the skin disorders, which I am going to discuss in next slide. So these next two slides are for mimickers of diaper dermatitis. Diaper dermatitis is treated very simply, which we are going to discuss later, but first you have to differentiate it because treatment differs. First mimicker of diaper dermatitis is irritant contact dermatitis. Means any irritant thing you are applying to the skin, that is going to have such kind of irritant contact dermatitis. The differentiating point is inguinal region, inguinal folds are spared here. You can see here. So sparing of inguinal and intertrigeal spaces are spared, means in between gluteal regions also will be spared, and the contact area will only show the lesions. Second is candidial diaper dermatitis. If candidial diaper dermatitis is there, we have to use antifungals here, but you should be able to diagnose that. How you are going to differentiate that from diaper dermatitis? Here you can see the satellite lesions. See, the lesions in the perineal region is there continuously. With satellite lesions, you are able to see it here. So this is candidial diaper dermatitis. Here you have to use antifungals. We'll move ahead. The two more lesions which are confused with diaper dermatitis is seborrheic dermatitis. Seborrheic dermatitis usually is seen over the scalp and face, but sometimes in perineal region you can see. But the discharge is like you can see that very cheesy discharge. When scales when removed, erythematous area will be down. Then it is seborrheic dermatitis. Seborrheic dermatitis usually needs antifungal shampoos and then avoidance of use of oil. and some skin care usually takes care of seborrheic dermatitis. And then Acro Dermatitis enteropathica, where eroded or crusted erythematous patches and plaques involving skin folds, perioral area and extremities with loose motions, if it is there, then it is Acro Dermatitis enteropathica. Zinc supplementation and local skin care definitely improves this. So diaper dermatitis should be differentiated from these lesions and then should be treated. So how we are going to treat diaper dermatitis? Diaper dermatitis is treated by using minimum use of diapers. Whenever it becomes wet, you should consider for changing of that. You should explain to the parents that diaper absorbs urine, but diaper doesn't absorb stool. So whenever the baby passes stool, you should consider for changing the diaper. After changing diaper, you should tell parents that you should not rub the area, perineal area, for cleaning the stool particles, but try to mop that clean and keep the area dry. And if it is not responding with the local measures, then you should consider for using local steroids and keeping the area dry. So prevention is more important. So these are the guidelines, newer recommendations for use of diapers. I think we are overshooting the time. So can I get 5 minutes? Milind sir, can I get 5 minutes?
Yes, yes, sure.
5 minutes. I will finish in 5 minutes.
Yeah,
so we are not going to discuss these newer recommendations, but you can go through. So another skin more important lesion is seborrheic dermatitis. So commonly we see in parents who come, who tell that, sir, when we apply oil to the baby's skin or जे टाळू माखणं म्हणतात ते टाळू माखल्यानंतर हे आमच्या बाळाच्या स्किन वरती असं येतंय आणि खूप जास्त खपल्या येत आहेत, काढल्यावर रेड राहतंय वगैरे. So clearly you can see that on the head of the child, such kind of scaly, greasy lesions will come. On face also you will find such kind of lesions. Usually what you have to do is first try to remove the stimulus which is causing that. So try to remove the oil, try to remove, means I usually tell that whatever you are applying, you stop, try to keep bathing of the child with water only. Don't use any oil, don't use any soap, don't use any powder till that lesion is get treated. Then use antihistaminics for erythematous lesions and emollients we consider. I may tell that few of the shampoos which are available for the head, like Spoo shampoo is there, so that can be used for treating seborrheic dermatitis. But it's a disorder which is very recurrent, so you have to tell parents that you should consider for treating long term with that and try to use minimum use of oils in such kind of babies. And usually they are infected with fungi, so antifungals are sometimes needed. Another important slide which I want to tell you here is these two slides you please keep in mind. So uppermost part is umbilical granuloma and lower part is umbilical polyp. Both of them you should keep these pictures in mind because treatment of them is totally different. Why? Because sometimes if you confuse umbilical polyp with umbilical granuloma, then a lot of complications are going to happen because umbilical polyp is nothing but a remnant of vitelline duct. And if you try to cauterize that, then it is going to have some kind of urological problems or intestine related problems. So how is umbilical granuloma? Umbilical granuloma usually appears after falling off part, that is after 7 to 10 days. And usually it is little bit lighter, not red as if umbilical polyp is there, and usually discharges clear fluid. Mother tells that ki sir याचं म्हणजे नाळ पडली आहे पण पाणी येतच राहते. Blood usually doesn't come through that, but polyp may bleed. Polyp doesn't have a clear secretion. So you should differentiate by seeing that. And if you are able to see, if you are confirmed that it is umbilical granuloma, try to treat with chemical cauterization, and another is electric cauterization. Chemical cauterization is done with NaCl, that is simple common salt, and if it is not responding, then you can consider for treating with pediatric surgeon with electrical cautery. And umbilical polyp needs altogether different treatment. You have to evaluate whether any other vitelline duct abnormalities are there and then treat that. Then 2 to 3 more slides are there. Just these are the life-threatening dermatological manifestations which you should know. One is sebaceous fat necrosis. It is commonly seen, see, being birth asphyxia, we are treating with cooling. So we see few of the babies with sebaceous fat necrosis. Usually they present with hypocalcemia, and hypocalcemia will have such a deadly complication. If it is not seen, not diagnosed properly, it may have dreaded complication. Second is herpes simplex virus, hand, foot, and mouth disease. Such kind of satellite lesions you can see in herpes simplex virus. So if baby is having extensive HSV, then you should consider for early use of acyclovir. Another life-threatening lesion is staphylococcal scalded skin syndrome. Here you have to use antibiotic as early as possible and try to use local treatment. The neonatal varicella, if mother is having varicella and baby is having lesions, you should explain parents risk of pneumonia as well as gastroenteritis. And in that condition, we can consider for use of Vesic, that is varicella zoster immunoglobulin, or and acyclovir. If Vesic is not available, we can consider for use of simple IVIG. Then epidermolysis bullosa, this is a multifactorial etiology. If previous baby is affected, the transmission is different. Autosomal recessive, dominant, X-linked, all kind of transmissions are possible. Epidermolysis bullosa, if it is extensive, it is a lifelong disease, usually have a very poor prognosis. Babies usually die because of hypernatremia or electrolyte imbalance, dehydration, and sepsis. You should take care of that, and then comes in the parents accordingly. Langerhans histiocytosis, usually neonatal age group presentation is very rare, but usually it is a disease which needs hematological association for treatment. Then this is aplasia cutis. You have to see that see there is loss of skin over the scalp and this hair target sign it is called as. So this is a target, and around that hairs are there, and over the see you can see leg there is a loss of skin, and you can see the eroded bone also. It needs skin transplantation and that. So these are the iatrogenic injuries where Swapnil is going to take care of the neonatal skin, which I'm going to hand over to him now. So these are the disorders which I'm not going to discuss in detail. So thank you very much. I have finished my lecture here. If questions are there, you can ask questions here, or by the end of the lecture also we can take, all lectures are over, we can take the questions. Milind sir, please.
Yeah. Thanks, Dr. Sandeep Patil, for such a nice talk on common skin disorders in neonates. Your talk was very well supported by the photographs of various lesions. It was like a visual treat for us. And thank you so much. Any questions? Okay, we can take questions later on also.
Yes,
so,
sir, yeah.
Moving on to next topic, Dr. Swapnil Bishikar, who is currently head of neonatology unit at New Era Hospital and is a super consultant at Colors Hospital also. He is going to talk on care of normal newborn skin. So over to Swapnil.
Yes, sir, yeah. Start in a minute. So, thank you, Milind sir. We will be discussing. Let me just share my slide. Are my slides visible?
No, not yet.
No?
Yeah, now the slides are visible.
Okay. So, since because of time constraints, I will be just discussing what are the 10 important steps for skin care in NICU babies. So problem statement is that around 4% of infant leave. This is an international standard data. That is 4% of infant leave the NICU with cosmetically or functionally significant scars. Now this rate of iatrogenic event are very huge. They're up to 57% with a low gestation, that is between 24 to 27 weeks. And for term babies, this incidence is only 3%. However, healing by scarring may occur if a basal layer of epidermis is involved and which generates epidermal barrier and is lost or damaged. Skin may be damaged because of piercing, cutting, stripping, or burning thermally. This is just theoretical, but all said and done, if the baby gets scar, it's very difficult and almost impossible despite long years of a developing science. So all the modality is for prevention for all kind of hampered event happen in an ICU. You can see this baby develop this kind of a burn rash post some procedure. This is very common procedure, umbilical catheterization we generally do, and subsequently next day or day after next that there is some kind of a erythema around that that catheterization area. Now these all are the example of nothing but a chemical burn happen with the use of either betadine, that is bodine iodine, or with alcohol with chlorhexidine. Now with concentration, which whatever being used, that is being studied for adults, they have found that there is no skin rash or skin burning happening in this kind of adult patient. However, if a gestation decreases, there is a more incidence of these babies getting harmed because of use of a normal concentration of a chlorhexidine or betadine. Also, this thin skin of a preterm babies absorb lot of a component from this solutions. Because of a betadine, there are reports of hypothyroidism or hyperthyroidisms, and also there are reports of neonatal alcohol intoxication by using 70% propranolol with the chlorhexidine. Now, how to prevent this thing? Three-step techniques is equally important and achieves antiseptic level with a diluted betadine as well as alcohol with chlorhexidine. How much dilution is required? Half to 1/3 is equally efficacious. Once you use this kind of a saline, or once you use this kind of a solution to clean, to make a aseptic area, leave this area for around not more than 5 to 7 minutes, and then again clean this area with saline. This is going to achieve equal asepsis. That saline should be, obviously the saline is going to be aseptic. It should be is going to achieve same level of antisepsis as compared to normal concentration of betadine and alcohol. However, the skin injury will be very much less if you dilute with the normal saline. Now, second slide, I will discuss regarding skin avulsion, which is very common after removal of adhesive. After removal of adhesive, this picture shows that the skin is being stripped off by after removal of adhesives. Now, the adhesive is being used for fixation of RT, fixation of multiple things, as well as fixation of temperature probe, fixation of urinary catheter. How to prevent it? These are the few things which I would like to just tell you regarding. Choice of adhesive should be medium grade. Dynaplast is very high grade adhesive. So always try to avoid high grade adhesive, and also the quality of adhesive should be that it should leave very low level of residual effect. Secondly, once you apply adhesive tape, whatever it may be, medium grade, low grade, or high grade, removal should be attempted only either immediately or should be after 48 hours. This 48-hour gap helps in loosening the adhesive strength, and there is less amount of injury. If you want to remove that adhesive after 48 hours, always wet the adhesive adequately with warm saline or using warm saline swabs. I will just recommend to use warm saline swabs and with a gentle pulling effect. Either you should not pull it, or you should just use that swab to remove the tape very slowly, and it should take at least 1 to 2 minutes or maybe 2 to 3 minutes. Should be slow. Should be slow. Never try to remove the adhesive if you are in hurry. Always try to remove the adhesive in horizontal directions, because skin lines, they are dermal plane lines, they are horizontal. That's why try to remove the adhesive tape in horizontal directions. If some kind of a injury happens, it will be along the dermal plane, and that can be recovered slowly if other planes they have some kind of recovery on that. Now, which should be used, duoderm or tegaderm? Now, duoderm is a leucoplast or which is being marketed. The duoderm have extra thin spot. Now, this thin spot helps in increasing the moisture when you want to remove with saline. and then comparison with the transparent film dressing, that is Tegaderm. When you want to fix it, nasogastric tube or orogastric tube, use either of it, because they are going to be equally efficacious in fixation as well as less injury while removal. However, there is one study which says that use of a deodorm is beneficial with less erythema if you remove it rather than Tegaderm while fixation of a nasogastric or orogastric tube. Now, there is a very wonderful drug which I have come across in the last few years, that is Silgrape. This is silicone-based tape. This silicone-based tape is such a wonderful thing that it leaves no residue. When you try to remove it, there is no erythema, very less erythema, and you can use it multiple times. The same silicone grape you can use it multiple times. However, it is a little bit costly as compared to, it is around 5 to 6 times costlier than the usual micropore or micropore, but it is very useful. Now we will come to injury caused due to pressure. Now you can see in this graph that the nostril that alar region is getting damaged because of RT, because of pressure. It is going to happen. Multiple cases of alar cutting has been reported with the use of RT if the pressure is very high. Specifically, when the child is in shock or is having altered circulations, the skin linings or cartilage linings has less strength, so that because of that the injury increases. Now, while fixation of RT, this should be kept in mind that up to end it should be supported. That which is entering inside the orifice, that should be supported. If it is flexible and if there is pull or pressure happening on the alar cartilage, it is going to cause injury. Now, there are multiple reports of post complications because of intubation, which are nothing but a dental complication which can happen with prolonged usage of endotracheal tube. These are just photos which shows that delayed eruption of a teeth, malocclusion, which can happen with improper fixation of a tubes. Now, for prevention, what we say that all foreign material can induce injury due to constant pressure. So remove it. You cannot say that RT cannot produce injury. It produces. We have seen in the previous slide. Some movement at the point of contact with body should be there. If it is too tight, if it is too loose, it is going to create some kind of a problem to the baby. In case if you need to replace it, always keep the opposite side in mind. If you find any kind of erythema or irritability of an unit due to the pressure, change it to either orogastric to another, that is nasogastric or orogastric. You can interchange it. None of the study has found that application of antibiotic cream helps in prevention or treatment of this kind of pressure injuries. So always prevention is better than cure for these babies. We have also seen this kind of burns being happening due to use of a pulse oximeter. Specifically, this lower pulse oximeter is very much dangerous. It causes pressure injury as well as thermal injury due to pulse oximeter. Now, it is being said that if a baby is exposed to around for thermal thing, if a baby is exposed to point thermal temperature of 44 degrees, a 6-hour contact is enough to cause second-degree burn. And if a contact period is prolonged, more than 12 hours, and the temperature is a little bit lower, that is 40 degrees, it is going to initiate first-degree burn. So always nursing care has to be, nursing people has to inform that they need to change the site of probe with after every during cluster nursing. Temperature probe also causes injury for babies. Is hemodynamically unstable. There is a lot of edema, and maybe this probe also produces pressure sore at the point of contact. So this is a good way in which that temperature probe can be fixed. You can see there are 2 tapes. In between the tape, that tubing is being kept, and only sensing material is being exposed to the baby's skin. Other probe is not putting any kind of a pressure on the baby. These kind of films, reflecting films, which are available in the market, mostly these are available in West market. However, you can put aluminum foil in between these 2 adhesives, so that it will help in reflection of the radiation, thermal radiation. Now, multiple sites of injury can happen with a CPAP. You can see a pressure sore being happen because of a flexi trunk which is being used of a Fisher umbilical device. These are the multiple injuries of septal injuries, which is very common as people are using CPAP more and more. There is lot of cases, lot of neonates they are suffer from injuries. And also, if the injury is very much deepened, then that is also an indication to put baby on invasive ventilation, because injury is going to take long time to heal. Now, all the guidelines which Fisher and Paykel or SP Care they are putting, that need to be followed. What are these kind of guidelines just to avoid or decrease the incidence of injury caused by pressure sores? That bonnet, the cap should be snugly fit. Don't attempt to make any kind of jugaad between smaller or larger cap, because fixing a bonnet, if a bonnet is good, then all the parameters will align in itself. If a bonnet is not, if a bonnet is very much loose, or if a bonnet is very much tight, that is going to cause, because CPAP is going to take around maybe at least 24, 48 or maybe more than that. If a bonnet is not good, the baby is going to have any kind of pressure sore because of this. So also there is a very people are using that pads which are used in flexi trunk. They remove it because of a proper alignment of this thing, which should be avoided. Pad the flexi trunk properly so that undue pressure is not there, and should not cause undue tension on that flexi trunk, which will avoid pressure sore at the forehead. Septal injury is very common, which is equal with CPAP mask as well as CPAP prongs. So there are various studies in which they have found CPAP prongs generate more injury. However, there is one study which has been conducted during my residency. They have found that with the help of us altering this mask with a prong, the injury is very much less. However, in both the things, you can use cannulate for prevention of septal injury. Also, HFNC is being rapidly being used nowadays. You have seen one photograph which Dr. Sandeep sir has shown you, that there is linear hyperpigmentation which is appearing because of a pressure area on child's face. However, while attaching HFNC cannula, you should keep in mind that the leak is a thing which should be there in HFNC. However, the prong should be horizontal. It should not be angular. It should not be in an angular area. It is going to cause more and should not be tight. The adult patient, there is different way in which this kind of cannula need to be fixed. However, in pediatrics, in neonatal babies, they need to be fixed in horizontal, completely horizontal fashions, and there should be some amount of a gap between the nasal septal as well as the ram cannula's edge. Another very much interesting part which I come across, there are a lot of sticking being applied on chest when you are going to put baby, when you need intercostal drainage. This causes injury to nipple while removing that sticking. This causes short-term as well as long-term complications for the babies. This can cause breast abscess in near term. And however, if a child is a female child, she is going to suffer a lot of lactation issues in her future. Now, this is the right way in which the ICD should be fixed. See, the nipple area is not at all covered, and the dressing is well. It has been well applied, and it is transparent, and you can identify a lot of erythema or any kind of issues associated with this thing. Now, this is all of us, we have seen such kind of extravision injuries in our residencies, this kind of dreaded complications which can happen, and this produces long-term scar for the babies. That muscle injury, that bone injury can happen with this thing. So most common culprit of this extravision injuries is calcium, lipid, and then TPN, also vasopressor for longer duration like dopamine, epinephrine. It produces intense local vasoconstriction which causes tissue ischemia. So how to prevent it? Don't use routine IV calcium. There is no study which says calcium हर एक baby को जरूरत है ही दो IV fluid पे है उसको calcium देना. It's not that way. Shift to oral calcium as early as possible. Vasopressor, inotropes. You have to regularly check IV side, which should be transparent with a transparent dressing, and it should be part of your routine examination. Overwork and altered nursing ratio helps in decreasing such kind of dreaded complications. multiple medical line of treatment like hyaluron enzymes, which will not be useful for kind of a treatment for such kind of injuries. So safety is always better for preventing such kind of injury. And another thing which we need to monitor for all the preterm babies who are in NICU is monitoring of overall skin conditions. Baby can become dry because of increased exposure to the radiant warmer. They can develop erythema. They can develop dryness. There is increased incidence of a breakdown or excoriation. So there is a format in which this baby can be examined. And if you find the baby is having his skin condition is getting more erythematous or more dryness or more breakdown is there, then you should have to increase or decrease your fluids and electrolytes accordingly. On this part, I would like to discuss. This is a tradition of an Indian society, that application of oil for all the neonate. However, application of oil in developed country, they found that is not useful, and on the other hand, there is increased chances of MRSA. However, there are 2-3 studies which are being published from developing countries. They have said that overall there is a less chances of electrolyte imbalance, less need of a more resuscitation, less incidence of sepsis by using oil application as a routine standard of an ICU care in care of NICU babies. However, application of petroleum gelling is abundant and should be avoided as a routine moisturizer in NICU babies. So with this thing, I would like to thank you, Milind sir, for giving me the opportunity. Thank you.
Thanks, Swapnil, for such a nice talk. Actually, most of the skin lesions are iatrogenic and we are preventable certainly. If we take proper care of the skin, then because these scars are going to remain lifelong. And actually, these days, while counseling in the initial phases, I tell the parents of premature babies that include the skin as organ also. Like there can be injuries, there can be lesions, and there can be problems with the skin as well. So thank you, Swapnil. Now we move ahead with our clinical case presentation. I request Dr. Kuldeep Sukhdeve to present his case. Dr. Kuldeep Sukhdeve is a teacher and presently working as a consultant and director at Kingsway Hospital. Over to Kuldeep.
Yeah. Milind, am I audible?
Yeah. Your slides are also visible.
Yeah. Thank you, Dr. Milind Mandlik. Having gone through the program for today, where the first 2 presentations were on skin, so I changed my topic and now I've taken a very small case, which I know it was a 3rd case, a very small case, so that we can finish as early as possible. So a newborn with a dark cutaneous lesion, born 5th of April, 2,400 grams, delivered by cesarean section at Baitul. And he came with a large black discolored lesion over the trunk and some areas of bleeding and discharge over the lesion. And both the parents were scared and depressed and came for further treatment. Maternal history, primary no comorbidities, and ANC scans were normal. On examination, hemodynamics are normal. There is no respiratory distress. Cardiovascular examination is normal, no organomegaly, and the CNS shows a normal cry, tone, and activity. Now, this is how the child came. This child came at day 3 of life, came with large brownish blackish lesion with well-defined borders, irregular surface present on the abdomen, back and thigh. There are a few vesicles. Some of those vesicles got broken, and there was some vesicles showed some bleeding also, small amount of bleeding. And there were multiple satellite lesions. We can see that there are multiple satellite lesions all over the face, chest, and all the limbs. So this is one of the most extensive lesions I have seen in my practice. He came on day 3 with a weight of 2 kgs, 220 grams, length of 44 centimeter, head circumference of 33 centimeter. These are the investigation, most baseline investigation. Everything was normal. Child came in an irritable condition to begin with, actually. So as much investigations possible were done, including blood culture, and everything was normal. So septic screen was normal. Baby was fine otherwise hemodynamically. The management was conservative. Pediatric surgeon had seen, and the pediatric surgeon had advised for a placenta extract, a placental gel. I wonder whether it works or not. And I had personally advised for an MRI at a later age. So this is a case of a congenital melanocytic nevus. All of you have come across congenital melanocytic nevus. Mostly they are small congenital nevi or intermediate nevi, but here you see a very large, or what is also known as a giant congenital nevi or congenital melanocytic nevi. What is the purpose of presenting this case? I understand that neonatologists and pediatricians may have very little to handle this kind of a lesion, but there is a lot of prognostic factors which are associated, and while we are counseling the patients, we are very, very careful as to tell them what is going to happen in the future. So these are hamartomas, which are composed primarily of clonal proliferation of melanocytes, and which happen exactly during the embryogenesis itself. They tend to extend deep into the dermis and subcutaneous tissue. Melanocytes track along or with the neurovascular and adnexal structures, that is hair follicles and sebaceous glands, and they can actually enter into the central nervous system as well. They occur in almost 1 to 3% of infants. Large or giant congenital melanocytic nevi would occur probably 1 in 20,000 births. The color of the nevus ranges from tan to black, and they are bordered often are geographic and irregular. And they have increased density of dark and coarse hairs over it. Over a period of time, we do not see hair at birth itself, but as the time passes by, and this is also sometimes referred as a garment or a bathing trunk nevi, and are frequently accompanied by multiple small disseminated satellite nevi, as I told you. What is the risk of developing melanoma? It's as high as 5%. And this is one of the reasons why I would say when we discuss prognosis for the future of the child, we should be carefully talking about all the issues. So there are at least two issues we must be discussing. One is a malignancy itself, and second is what is likely to happen in the central nervous system. So they tend to grow very rapidly, at least in infancy. They are often flat, early pigmented patches. Later they become elevated, pubbly, verrucous, or cerebriform surface. They are located in the scalp. If they are located in the scalp, they have a tendency to gradually lighten up, and occasionally it can regress. During the neonatal period, transient erosions or ulcerations are likely to be seen. So this is exactly what we saw, some ulcerations, and that is why some places it was just oozing, and the other places it was bleeding, actually, when the baby was brought to us. So what can happen? One thing which can happen to this child is a melanoma. This is one reason why, if we say nothing is going to happen, you can now go home, this is going to just remain like this, we might make a mistake. So that is about it. They would probably occur after puberty and tend to rise at dermal epidermal junctions, and especially true at least when we have these giant nevus. So this child, as I can see, most likely to develop some or other problem when this child grows up, and thus we need to keep this child in our attention. So this is another one, this melanosis, neurocutaneous melanosis. This is likely to happen, as I told you, specifically in those newborns who have a very large or whole of the trunk and 50, 60, 70 satellite lesions there. And so at least when we have got these 2-3 reasons, a large nevus, especially more than 40 centimeter, and has a posterior axial location like this child has, a lot of satellite nevi, and more than 2 medium size nevi as well. So these are the kids who are likely to develop NCM most likely. How do we do it? We get an MRI done. So if you see one of my slides, I said we have to get an MRI done. So maybe between 3 months to 6 months is the best time to get the first MRI done, and we can have problems related to both leptomeninges, number one, and the cerebrum itself, and they can end up leading to intracranial hemorrhage, impaired cerebrospinal fluid circulation, spinal cord compression, malignant transformation of the melanocytes inside the central nervous system. They have the poorest prognosis. And how do you manage this kind of a CNS or a neurocutaneous melanosis? An early surgical removal is often desired, number one. And patient with large CMN plus multiple satellites like the one which I had presented now should be followed with serial head circumference measurements, neurologic examinations, and developmental assessments. But how do you manage? Now, management, as I saw in a couple of books, it remains extremely controversial, extremely so much so that some of the text wants you to have early excision and repair added by tissue expanders and grafting and so on and so forth. I wonder if any of us are doing here, at least in Nagpur. How do we follow up now that this baby is born? You look for associated problems and morbidities, and now we happen to discharge. So what should we do? We should ask them, Nevus cell, that what should we follow up for? So we should follow up for whether the baby requires biopsies, follow up every 6 months for 5 years, then every 12 months, and serial photographs if things are changing, if the color is changing, if it is converting into a melanoma, and so on and so forth. So that is what, in a short, one child I presented with such a nevus. Thank you very much.
Thanks, Dr. Kuldeep, for such a nice case. Actually, it was related to neonatal skin, so made it interesting. And definitely would like to know the follow-up of this child.
Yes.
Thank you. Yeah.
Thank you. Thank you.
So any questions to the faculty?
So any kind of, are there any lymph nodes enlargement in this baby?
This newborn, no, lymph nodes are not enlarged, and there was no edema also. I was expecting some edema to be there. Incidentally, there was no edema, no lymph nodes, no jaundice.
Okay.
So it was anyway, I saw the child at day 3 of life and discharged the child at day 6 of life, and that is all about it. Now that today when I saw that there are 2 presentations on skin, so I took up a skin case. So now I realized that I have to ask one of my residents to call them and now ask them at least for a few questions now.
Right, yeah. So on behalf of Neonatology Forum Nagpur, I would like to thank the faculty, Dr. Swapnil Bishekar, Dr. Sandeep Patil, and Dr. Kuldeep Sukhdev. Also, I would like to thank all the delegates who took time to join this clinical meeting. I'd like to thank Prakash from SS Events for giving us the technical support. And thank you all. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Congratulations, Kuldeep.